Welcome to today's ASPC CardioCore Lecture Series. We're pleased to have you with us for this presentation, New Lipid Guidelines, presented by Dr. Roger Blumenthal. Dr. Blumenthal is the Kenneth J. Poland Professor of Cardiology, Professor of Medicine, and the Director of the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease in Baltimore, Maryland. Dr. Blumenthal graduated with honors from both the Landon School in Bethesda and Johns Hopkins University. He did his internal medicine training and cardiology fellowship training at the Johns Hopkins University School of Medicine before joining the Hopkins cardiology faculty. Dr. Blumenthal's principal clinical and research interests involve strategies to improve cardiovascular risk assessment and the optimal management of atherosclerotic vascular disease. He is an expert in the pathogenesis, treatment, and the prevention of cardiovascular disease. Please join me in welcoming Dr. Roger Blumenthal.
Thank you very much, Ashish, for the introduction. I'm looking forward to going over with the audience the top 10 messages about the ACC, AHA, Multi-Society Dyslipidemia Guidelines. I have no disclosures, and neither did my co-chair, Dr. Pam Morris. First off, wanted to remind everyone that our document and our work was built on the pioneering work of the late Scott Grundy and Neil Stone. Neil led the 2013 guidelines, and Scott led the 2018 guidelines, which Neil was the vice chair on, and we refer to them as the Jordan and Pippin of preventive cardiology. Well, Dr. Morris and I had our kickoff meeting with our esteemed group of guideline writers on October of 2024, and we called them the Prevention Dream Team. The first Dream Team was this great basketball team of Chuck Daly from 1992. But our preventive cardiology Dream Team had input from 11 different medical societies. We had experts in imaging, genetics, lipidology, pediatric cardiology, and it was really a pleasure to help lead this group with Dr. Pam Morris. So the charge to our writing committee was to create a living document that hopefully will be updated yearly, and to cut down on the need for separate ACC consensus documents. We had a lot of mid-career associate professors on the committee. We wanted to create a deep bench of candidates to lead future preventive cardiology guidelines. We wanted to create a document that highlights optimal medical and lifestyle treatment, and we tried to brainstorm on how to enhance implementation of our work. The rationale was that it would be about 7 years since the prior guideline. There have been 5 new non-statin therapies that had been approved by the FDA, and they weren't included in the prior guidelines. Bempedoic acid and glycerin evinacumab, and 2 medications for familial chylomicronemia syndrome. And we have a new improved risk calculator that we thought was very important to try to work into the guidelines. Well, those of us in the audience who have a little bit of gray hair will remember the early days of statin therapy. Mevacor or lovastatin was the first FDA-approved statin. And over time, we had more pills, ezetimibe, icosapent-ethyl, bempedoic acid, fibrates. We also have monoclonal antibodies at our disposal, antisense oligonucleotide antibodies, silencing messenger RNA, and a whole host of things on the horizon to lower LDL and non-HDL. And the next big frontier will be to see whether or not lowering Lp(a) translates into subsequent cost-effective benefits. So now we'll go over these top 10 take-home messages that we worked hard to focus in on for our guideline. Number 1 was that we wanted to treat dyslipidemia earlier to reduce lifelong risk of prolonged exposure to atherogenic lipoproteins. We stress that health behavior counseling to support lifestyle optimization needs to start in youth. Clearly, pharmacotherapy of young people with familial hypercholesterolemia was encouraged. And in young adulthood, meaning people age 30 and above, if they have LDLs persistently equal to or greater than 160, or a strong family history of premature disease with suboptimal lipids, they should be given strong consideration for starting medications sooner rather than later. This is a nice graphical display of that start earlier to reduce lifetime exposure to LDL concept. And we also added in the idea that a high 30-year risk of ASCVD should also be another indication to consider lipid-lowering therapy. So we want to treat people earlier, even if the 10-year risk is low, especially if their 30-year risk is high. And you can assess 30-year risk in people aged 30 to 59 with the PREVENT equation. Well, one of my favorite slides was an early collaboration between Dr. Anne-Marie Navarre and Eric Peterson. They were both at Duke at that time. And essentially, it was looking at how many years of hyperlipidemia defined as a non-HDL greater than 160, which corresponds to an LDL of 130 or higher, did the individuals have. And if they had no years of hyperlipidemia before the age of 53, then their event rate of the subsequent 15 years was about 4.5%. But if they had 11 years or greater of LDLs greater than 130 or non-HDLs greater than 160, their event rate was 4 times as high. And my close colleagues, Dr. Aaron Mikos and Seth Martin, wrote the editorial for this article, and they closed with this great quote of Theodore Roosevelt: "Old age is like everything else. To make a success of it, you've got to start young." And our guidelines wanted to have people think about their cardiovascular risk at a young age and take steps to move things forward. And I should say that this early collaboration between Dr. Anne-Marie Navarre and Dr. Eric Peterson matured, and about 10 years later, they had a son by the name of Knox. So a lot going on in the preventive cardiology world. Well, take-home message 2 was that we should use the more contemporary PREVENT equation instead of the older pooled cohort equations for 10-year as well as 30-year risk assessment. And this is to guide lipid-lowering therapy and primary prevention. And the PREVENT allows us to assess risk as young as age 30 and as old as age 79. We use the CPR model that Donald Lloyd-Jones has emphasized since our last set of guidelines. C for calculate 10-year ASCVD risk. P for personalized estimated risk to specific patients by considering factors not in the PREVENT score. So these are the risk enhancers. And then possibly reclassify a person's risk categorization with selective use of coronary calcium. And then finally, to reassess treatment recommendations as part of a clinician-patient benefit risk discussion. Well, my colleague, Dr. Sadia Khan at Northwestern, was named one of Time's top 100 people in the health field. She was extremely excited about this. Her enthusiasm went down a little bit when she found out that Dr. Oz and RFK Jr. were also on that Time 100 list. But nevertheless, Dr. Khan gets so much of the credit for her work at assessing 30-year risk in younger people. So we are able to calculate 10-year risk for patients 30 to 79, the 30-year risk estimation if they are 30 to age 59. P stands for personalized risk assessment, to look at those risk enhancers that we talk about. And selective use of coronary calcium if the person is at borderline or intermediate risk and the decision about lipid-lowering therapy is still uncertain. And R means to really reassess the need for lipid-lowering therapy. We know that the pooled cohort estimates were known to overestimate the 10-year risk, and a great paper by my colleagues, Dr. Andrew DeFilippis and Mike Blaha in the Annals of Internal Medicine was one of the first to point this out, as was a paper by Paul Ritker soon after the 2013 guidelines came out. The PREVENT ASCVD 10-year estimates are lower than the pooled cohort estimates for intermediate risk, We now say intermediate risk is 5 to 10% for the prevent score. And previously with the pooled cohort equation, we said it was 7.5% or higher. Keep in mind that we have data from the AFCAPS TextCAP study using lovastatin, where event rates went from 5.5 down to 3.5%. So we really do have data with statin therapy in this lower risk individuals. Well, we know that the risk enhancers are very important to personalize a person's estimated risk. We first think about the demographic and genetic factors, a family history of premature disease, high risk ethnicity. We added Filipino into South Asian, high polygenic risk if ordered. There's a great paper in the JACC that just came out from Pradeep Natarajan's group that talks a lot more about polygenic risk scores I encourage people to look at. Next is the clinical conditions that increase risk, chronic inflammatory diseases such as lupus, inflammatory arthritis, psoriasis, CKM syndrome, and reproductive risk markers. And then the blood tests, the biomarkers, persistently high hsCRP, elevated triglycerides, elevated LDL, and a high Lp(a). Well, this reminds me that we had a great paper by Dr. Ridker's group, came out in September of 2024, just before Dr. Morris and I officially started our guideline. And there's going to be another guideline with Dr. Chadi and Dumle, who's pictured here with Dr. Morris's significant other two. And this was a picture taken at the ESC at Amsterdam. Time certainly flies. And the title of an editorial that Dr. Martin and I wrote was Prevention of Cardiovascular Disease, Don't Stop Thinking About Tomorrow, and clearly a nod there to Fleetwood Mac. Well, the take-home message 3 is that LDL lowering therapy can be considered in adults for primary prevention with a 10-year prevent ASCVD risk estimate as low as 3 to 5%, which is borderline risk, but definitely should be strongly considered in those in that 5 to 10% range after a clinician-patient benefit risk discussion. And this is shown graphically where low risk is less than 3%, borderline risk 3 to 5%, intermediate risk is 5 to 10%, and high risk being greater than 10% in our estimation. Some clinicians may say for their way of thinking high risk would be a larger number, say 15%, but this is what our dream team of preventive cardiology would recommend. Well, we've come a long way since the debates that I had with my longtime friend, Dr. Rita Redberg. This was from a cartoon that Chris Cannon commissioned for CardioSource, and she had the view that statins are warranted strictly in secondary prevention, but without evidence for use in primary prevention. She had the overly bold statement of saying statins in primary prevention is like opioids in patients with non-malignant pain or proton pump inhibitors in persons with non-ulcer dyspepsia. And Dr. Cannon commissioned a nice artist here, and I came back with a strong quote. With all due respect to Dr. Redberg, that logic is as fractured and twisted as Joe Theismann's tibia and fibula after he met Lawrence Taylor in the Redskins backfield on Monday Night Football in 1985. I think there's still people who are very skeptical of statin use in primary prevention. I think that's like putting your head in the sand, and we really need to show the data to patients and help them make that decision. Well, take-home message 4 is memorialized in a great song that you can get on YouTube by Anne-Marie Navarre. LDL and non-HDL treatment goals are back, baby. And this can guide lipid-lowering therapy. The percentage reduction in LDL remains a priority for all individuals as well. And for higher risk patients, you'd like to get a 50% reduction or greater in higher risk individuals. So what are the key numbers to remember? I would say that all of us should strive for an LDL less than 100 in borderline to intermediate risk individuals. High risk individuals, we said, an LDL less than 70, and very high risk individuals even lower, 55. And we made the ApoB targets in high-risk individuals and very high-risk individuals the same as the LDL targets. Take-home message 5 was that ApoB testing can be useful to improve risk assessment and guide treatment once LDL and non-HDL goals are met, particularly in those with elevated triglycerides, diabetes, or low achieved LDL in the range of 70. ApoB measurement helps identify people with residual elevated lipoprotein-related risk in these groups of people that may be underestimated by a standard lipid panel alone, and it may be useful in the diagnosis of specific lipid and lipoprotein disorders. I really would not advise ordering an ApoB every time you order a lipid panel. I think that's a waste of money. We should first achieve those LDL and non-HDL goals. We should consider ApoB when the LDL and non-HDL goals are met, especially in people who have cardiometabolic syndrome, or what is now called cardiovascular kidney metabolic syndrome, diabetes, elevated triglycerides. And if the ApoB is above the goal, even though the LDL is at the goal or below it, treatment should be intensified. And keep in mind that ApoB represents the total number of atherogenic lipoproteins, and ApoB is not affected by food intake or fasting to any appreciable degree. Take-home message 6 was that Lp(a) should be measured at least once to identify those individuals at higher risk. It's a risk enhancer at levels above 125 nanomoles per liter, and that's associated with about a 1.4-fold increased risk, so a 40% increased risk. And we also pointed out that values of at least 250 nanomoles per liter are associated with about a doubling of estimated risk. So the presence of an elevated Lp(a) should be an indication for more intensified LDL lowering and management of other risk factors. In terms of Lp(a), we said that if you had a value of 430 nanomoles per liter, that's associated with about a 4-fold increased risk. And we want to remind clinicians that Lp(a) levels are largely genetically determined and mostly stable over a lifetime. And if it's high once, you don't need to measure it again. Next, take-home message 7, coronary calcium scoring in men at least 40 years of age and women at least 45 years of age can improve risk assessment and guide LDL and non-HDL goals. And both the absolute amount of coronary calcium and the corresponding standardized percentile, which is based on age, sex, and race, have prognostic importance and help to reclassify risk in adults. And you can get this from the MESA website. You can simply Google MESA and coronary artery calcium, or MESA and CAC. So here's a nice graphical display of how a coronary calcium score may help the clinician. If a person has no coronary calcium, it may be reasonable to defer lipid-lowering therapy over the next 3 to 7 years, and that would apply if they're not high risk, meaning they don't have diabetes, they don't have a strong family history, they're not smokers, and you could repeat a coronary calcium scan in 3 to 7 years. For individuals who have mild coronary calcium in the range of 1 to 99 or greater than the 75th percentile, an LDL less than 100 is very reasonable. For moderate coronary calcium in the 100 to 300 range, an LDL goal less than 70. Above that, we have an optional LDL target of less than 55, and certainly when they have a really high coronary calcium score and LDL target of less than 55. So keep in mind that incidental coronary calcium in a non-gated CT can also be used to guide therapy. If there's some mild coronary calcium, certainly supports an LDL goal less than 100. If it's moderate or severe, an LDL goal less than 70. But the absence of incidental coronary calcium should not be used to defer lipid-lowering therapy, given the relatively low negative predictive value on non-gated scans. And the gating refers to ECG gating, trying to get the pictures during diastole when the heart's not moving as much. So take-home message 8, LDL lowering therapy is recommended for primary prevention in adults age 40 to 75 who either have diabetes, chronic kidney disease, stage 3 or 4, or HIV infection, regardless of their LDL level. And certainly this can also apply to people younger than the age of 40. After the age of 75, LDL lowering pharmacotherapy can be considered in conjunction with lifestyle intervention to reduce risk. But truthfully, a person's biology really doesn't change if you go from age 73 to age 76. So I usually say if you're young enough to come into the coronary care unit at Johns Hopkins, you're probably young enough for me to help manage your cardiovascular risk factors. So here's graphically patients with CKD, HIV, or diabetes, statin therapy if the LDL is above 70. For cancer, we said continue lipid-lowering therapy unless contraindicated. We gave a weaker indication to use a statin in people who are going to be prescribed an anthracycline. The European guidelines actually gave it a 2A indication. And we gave some guidance about individuals who are pregnant or contemplating pregnancy, and including consulting a dietitian if someone has elevated triglycerides or higher LDL makes sense. And if triglycerides are high after the first trimester, certainly one can consider a fibrate or omega-3 fatty acids with high dose EPA. For chronic kidney disease, we said that in middle-aged people with CKD stage 3 or higher and an LDL of at least 70, you want to use at least a moderate intensity statin plus or minus ezetimibe. In individuals who have clinical ASCVD and CKD, then we want to aim more likely for a high intensity statin plus or minus ezetimibe and or a PCSK9 inhibitor to get the LDL down less than 55. And we gave a weak indication, class 2B, for those on maintenance hemodialysis who also have dyslipidemia. And I think the clinician-patient benefit risk discussion is very important in this group. So the REPRIEVE trial demonstrated that in patients with HIV, pitavastatin 4 milligrams daily led to about a 35% reduction in the risk of first major adverse cardiovascular event. And we would say that you ought to consider drug-drug interactions between lipid-lowering therapies and antiretroviral therapies. And we gave that a core 1 recommendation. Though adult cancer survivors with life expectancy of at least 2 years who would qualify for lipid-lowering therapy should be treated. And we gave a 2B indication, as we said before, to help prevent anthracycline-induced cardiotoxicity. The EAS guidelines gave it a 2A indication. In secondary prevention for take-home message 9, we want to have a goal of less than 55 for those at very high risk, and probably a smaller number of people who have atherosclerosis are not at very high risk, and LDL goal of less than 70 is reasonable for them. Many of the audience would probably like to bring up the Vesalius study, which Dr. Ndumile and I wrote the editorial for, and we have to remember that Vesalius was comparing an LDL of 45 versus 109. It wasn't comparing an LDL of 45 versus 70 or even 75. So it'll be good to look at those cost-effective analyses, but I would venture to say that almost all of us looking at this CardioCore presentation would probably favor the lower LDL goals if we can get there with generic medications and necessary more expensive medication. So we used to talk about primary and a half prevention, individuals who hadn't had an event but had a high coronary calcium score. And I think that we have to think about the Vesalius study, since some of the people got in with calcium scores of 300 or higher. We do know that there's a level of coronary calcium about 300 that corresponds to a risk consistent with established ASCVD, and we thank Matt Budoff's team for identifying that. And we included bempedoic acid and glycerin in the treatment algorithms. So for most individuals, as we said before, who have ASCVD, they'll be at very high risk, and through a combination of lifestyle modification and at least two medicines. We'd like to try to get LDLs of at least less than 55. Most people will start off with a maximally tolerated statin and ezetimibe, and then the discussion is whether to add bempedoic acid versus a PCSK9 inhibitor. And we await the clinical trial data with inclisiran, but we expect that that will also turn out to be beneficial. And then finally, our take-home message number 10, we said in patients with persistently elevated triglycerides, statin therapy remains the foundation of pharmacotherapy as an adjunct to lifestyle intervention to reduce risk. Treatment to prevent pancreatitis may include fenofibrate, may include high-dose icosapent ethyl, but we want to keep the statin going. Clearly, lifestyle is the first-line treatment for all those with elevated triglycerides, emphasizing weight loss and increased moderate to brisk activity. So keep in mind statins, first-line treatment to lower triglycerides and lower people's risk. And then we have the option of high-dose EPA and fenofibrate for those on a statin. And we have data with a couple agents now for patients with familial chylomicronemia syndrome. So as we wind up here, I always like to cite the key phrase of my longtime friend and colleague, Dr. Bill Belichick. Here's a Super Bowl ring. It's from an exhortation. It's from an editorial that Dr. Torsten Leuker from Hopkins and I wrote that accompanied Matt Budoff's great article. And the quote is that clinicians and patients need to follow the familiar exhortation of legendary football coach Bill Belichick to do your job. And this refers to the need to optimize lifestyle habits on the part of the patient and use proven pharmacologic therapy. But as clinicians, we need to emphasize that lifestyle improvements at each and every visit. As you may have guessed, this is a longtime Patriots fan. This is a picture of 8 of my favorite people. We have the Beatles on the right. We have Tom Brady, Rob Gronkowski, Coach Belichick, and a picture of my young son, Ross. And I got this from Anne-Marie Navarre, this theme of just cross the road early. Don't wait for the cars to be close to run across the road, meaning that deal with your risk factors early. If you have persistently elevated lipids, get them treated, work harder on lifestyle modification between each and every visit. So I think that's so important. And we'll leave you all with this fun picture, sort of modified members of Fleetwood Mac. There's Dr. Morris, Dr. Seth Martin, and yours truly. And we ended that editorial with clinicians should stress that the best way to avoid cardiovascular disease is to follow the AHA's Life's Essential 8 construct, since tomorrow soon will be here. So take charge of your health early, and thank you very much for your attention, and look forward to a great discussion.
Before we begin our discussion today, I want to thank all the attendees and members of the ASPC. If you're not a member, we would like to extend an invitation to join the ASPC. There are many benefits to being a member, including access to the online community of thought leaders in preventive cardiology, Doc Matter, exclusive pricing to attend our annual Congress on CVD prevention, and access to member-only content. So please consider joining today at aspconline.org/membership. With that, let's turn to our Q&A session with Dr. Blumenthal. So first of all, Dr. Blumenthal, thank you for that wonderful overview of the updated 2026 dyslipidemia guidelines. A lot of amazing learning points for everybody. Let me start off with some questions here from our audience. So if the apolipoprotein B level is normal or seems at goal, but the LDL cholesterol doesn't appear at goal, how do we handle that situation in a guideline concordant manner?
Thanks, Ashish, for the great question. With our guidelines, we said that we should aim to get to our LDL target first. And once we did that, then measure an ApoB. obviously some people may measure an ApoB earlier, and I think no one really knows for sure. It really doesn't make a difference if let's say the LDL is 65 and the ApoB is 72. But we generally would think that, if we could get both of them down, say below 70 in a higher risk person, that makes sense. And in a very high risk person, less than 55, but we really don't know for sure how much extra bang for the buck we're getting. And if one of them is, say, 5, 7, milligrams per deciliter higher than the other.
Well, thank you for that again. I think a topic certainly worthy of additional research, but once we start getting to those sort of lower ends, it's hard to know, as you mentioned, what we're getting from additionally targeting ApoB and LDL. But I agree with you. Our practice is also to get the LDL cholesterol down to goal first, and then check an ApoB when we feel it may add value. Could you comment, Dr. Blumenthal, on the use of aspirin for primary prevention with a high coronary artery calcium score?
Good question, Ashish. I think, the best paper was done, led by two of my colleagues, Miguel Cainsos-Echerica and Mike Blaha from Hopkins. And it was a modeling paper. And, what we concluded is that if you looked at the number needed to treat versus the number needed to harm, we used a 12% relative risk reduction for aspirin. And the number needed to harm was for a major GI bleed. And when you got above a coronary calcium score of 100, it certainly favored the use of aspirin, but it was a clear differential once you got to a coronary calcium score that was higher in that 300 to 400 range. So I tell people that aspirin's beneficial, but probably not as beneficial as many of us would have thought in the primary prevention setting, but certainly would start thinking about it when the calcium scores are above 100 and certainly above 300.
Wonderful, thank you. A lot of discussion about lipoprotein little a these days, a lot of clinical trials in progress and some close to completion. What are your LDL cholesterol goals for somebody with an elevated lipoprotein little a level, and how does a calcium score of 0 play into your decision making?
Another excellent question. So, the undercurrent of our guidelines was that, if you had a higher Lp(a), we should be really aggressive in lowering the LDL to counterbalance most of that adverse effect of the higher Lp(a). And in my mind, I usually tell our residents in Hopkins and students at Hopkins, I think about trying to get to an LDL in the 70 range or below. If you start off with someone whose LDL is much higher, let's say, 160, 170, it may very well be that, just getting down into the 90s could be, sufficient, with generic high intensity statin and ezetimibe. But, sometimes you need to spend more money for bempedoic acid or a PCSK9 inhibitor. And, from the cost effectiveness point of view, it's hard to give absolute numbers, but I think for the audience, thinking about an LDL of less than 70 certainly makes sense, Ashish.
Perfect. Yeah, no, I completely agree. And our practice is again very, very similar to that. Can you comment a little bit about somebody with an LDL cholesterol greater than 160 milligrams per deciliter? It's mentioned as a risk enhancer, but also as an indication for statin therapy. How do you approach decision making around lipid-lowering therapy?
So I'll first mention our blood pressure guidelines that came out in September, and they were pretty aggressive in my opinion. They said if your blood pressure was above 130/80 and after 6 months of lifestyle modification, they'd go ahead and treat you no matter what your age would be, give strong consideration to pharmacotherapy. And we really felt the same way. If you got to age 30 or above and your LDL is above 160, we felt that was much too high. In the prior guidelines, we said, if you had FH with LDLs in the range of 190, that you should go ahead and treat. But there's still going to be plenty of people, Ashish, who will say, "Doc, no one in my family has had any heart problems. I don't know anyone who's had a heart attack or a heart failure." And since no one really dies of heart disease in our family, not that keen on starting on a medication. So we'll try to. Many times we'll make compromise with people. We might say, "Well, how about rosuvastatin 2 or 3 times a week. Let's at least get you down from 165 to 100." And I try to do that, and they may still say, "I don't want to deal with any side effects." And I tell them, "Well, if we're only giving it to you twice a week, I think the chances you'll tolerate that are probably 97 out of 100." So I try to use psychology, as I'm sure you do at Cleveland Clinic, and because we all feel that greater than 160 is too high. And it's true that we did list it as a strong risk enhancer. I think it comes down to the clinician-patient risk discussion. You and I had plenty of patients who say, "I'm not going to take a statin or any lipid-lowering therapy until you can prove to me that I have end organ damage of some sort." And some of those people have calcium scores of 0, and their LDLs are 165, and I would say they probably have some good genetic factors that are protecting them. And I think you and I would try to get the patients still to think about a statin to get their numbers down, but some patients will still balk on that. So it's one of those things where some more research hopefully will shed some light on, and maybe we'll find out more from genetics and polygenic risk scores of identifying which people are really protected in some way from atherosclerotic disease despite having considerably elevated LDLs.
Yeah, and I couldn't agree more with that really nuanced kind of answer there. A lot of emphasis on shared decision making, transparency with patients, and establishing that therapeutic relationship, I think, can really clarify, where the patient wants to go and where you would recommend, and kind of marry those two to hopefully come up with a way to reduce their risk in a way that's sustainable for them, but also something that we're cognizant of, that it reduces their LDL cholesterol. So, thank you for that incredible nuanced answer. Here's a slight shift, a question about body mass index and South Asian populations. We know that South Asian populations at a lower body mass index have comparable risk. How do we take that into account when we're assessing people, when we're calculating their prevent risk score, if we're seeing somebody of South Asian ethnicity?
First, I'll remind the audience that we actually added people of Filipino ethnicity also to be high risk. And there's some consideration also, in looking at the data about patients that are Native Americans, because in my mind, less weight gain is needed in these ethnic groups to develop insulin resistance or diabetes. So in my mind, Ashish, I've always sort of thought of a BMI of 30 in a Caucasian might be the same risk in a South Asian or Filipino as a BMI of, say, 26 or 27. So, in terms of waist circumference, some of the data in the past, we've used 40 inches for a man and 35 inches for a woman that are Caucasian, but if they're of South Asian descent, then lower numbers, maybe 37 inches in men, for instance, and 32 in women. So there clearly are differences in susceptibility, some of which may be genetics, some of which may be lifestyle. But the questioner brings up a really good point, and I think many times you and I are looking for really any excuse to try to motivate our patients more to make the sustained lifestyle improvements, and we'll have a lower threshold to start medicine sooner, and we can control their lipids then for a longer period of time, then we have more time in our patient encounters to spend more time problem solving with them, ways to improve their lifestyle. So that's sort of the way I look at it.
That's great. I completely agree with that. We have another question here about nuanced decision making. In an individual with HIV over the age of 40, let's say their calcium score is 0. Would you recommend the initiation of a statin, or would you recommend deferring and repeat a coronary artery calcium later?
Another, very good question. I think, a calcium score of 0 is really helpful. I tell people for assessing the risk over the next 5 to 7 years, but there's reservations about how protective that's going to be over the next 10 to 15 years. So in my mind, I probably have a lower threshold to try to convince patients to start on some lipid-lowering therapy earlier, despite a coronary calcium score of 0. A lot depends on where they're starting from. If their LDLs of 140, 150, again coming back to sometimes if they're dead against going on statin therapy, I'll still say, well, how about twice a week? And we've had data a long time ago from Emory that showed that twice a week rosuvastatin may very well lower LDLs by about a third. So that could get us in good shape, and I try to also remind them about what the blood pressure guidelines are, that we really feel like 130/80 is sort of the upper range of normal, and we're trying to strive to get down below that. And I think the other point of our guidelines that we had the pleasure of co-chairing with Pam Morris was that we really wanted to get people thinking that a good LDL target for all of us in the primary prevention setting should be less than 100. And I try to remind people of that. And when your LDLs are 140, 150, that's a pretty high percentile for their age. So we definitely would want them to rev up their lifestyle. And, if they can't get there, then, we need to think seriously about a medication. But again, as you said before, it all comes down to that clinician-patient benefit risk discussion.
Oh, thank you. What a great answer. So here's a nice question, a little bit of a question on statin side effects. So what are your thoughts on studies that link statin therapy with an increase in hemoglobin A1C levels?
So we've known for a long time that patients, especially on high dose statins, maybe about 20% higher, they may have a 20% higher risk of getting those glucoses that were in that 100 to 124 range to go, above that magic 125 level. And there's probably some genetic differences too. Some people may be more prone to having that happen as compared to others. But for instance, in the Jupiter study that Paul Ridker led and published in, I believe, 2008, even those people who were in that pre-diabetes range, who migrated just a little bit above the 125 mark, the relative risk and absolute risk reductions in cardiac events, far outweighed in my mind those that relatively minor increase in A1C and in glucose. So I tell patients, especially if they're a little bit overweight, it's possible that their A1C may go up a small amount, but if they improve their dietary habits and improve the exercise routine, that probably will prevent that from happening. So we don't have perfect medications, and some may have some off-target side effects, but the mild rise in Glucose or A1C is something that we can deal with. And I try to still stress with the patient how important the data is that you can lower events significantly, even though the A1C or glucose may marginally increase.
Yeah, I fully agree with that answer, especially the part about, potentially discussing the mild real nature of that risk and using that as motivation for lifestyle optimization and cardiometabolic health optimization. And then you're sort of getting, even more comprehensive risk factor control while still gaining the benefits of the statins, which, one would assume that the rise in hemoglobin A1C is baked in, so to speak, in the trials of statins that showed outcome benefits. So, thank you for that great answer. And then this is a bit of an interesting question, and maybe we can have a little discussion about it. Is it important to think about if the mechanism of LDL increase, if someone is a hyperabsorber, so to speak, or a high producer of cholesterol in the liver, so to speak, to favor ezetimibe first before going to statin therapy? Is there any reason to think mechanistically before deciding on the right lipid-lowering therapy?
Interesting question. I think, we have one study of ezetimibe in primary prevention, Utopia, in patients 75 and older, and did show a nice relative risk reduction. We have the Improve It study that our friends Harlan Krumholtz and Eric Topol weren't very impressed with, and Steve Nissen, your colleague, really hated ezetimibe as far as I recall, and so did the editor of JACC. But there was a 7% relative risk reduction, and they would point out that the trial population and Improve It was about 17,000 people. So they, many times I heard them say, that's the only reason it was statistically significant. We had such a huge population. So, in my mind, the data with statins, in terms of relative and absolute risk reductions, is certainly much more impressive than ezetimibe. But I think it's an easy thing to add in patients who can't tolerate a full dose of a statin. I think the percentage of people who are hyperabsorbers and really get a big drop in their LDLs with ezetimibe is on the lower side, but it's very hard to predict. You really can't predict by looking at the patient. So I still favor in the land of the Baltimore Orioles, going with the statin first, and not sure what in the land of the Cleveland Guardians what Steve Nissen would say, but I think statin first. But clearly, if there's people who say, "Doc, I'm not going to take a statin," my Aunt Millie's hair fell out and she got all these cramps and it's never going to take it. Well, then fine. We'll start off with ezetimibe and we'll deal with that. And luckily, as you know, as well as anyone, there's so many potential choices that we can do. And sometimes, I may start on a ezetimibe, and then if I still feel like we need a little bit more lipid lowering, I'll say, well, maybe that suggestion of twice a week of a statin, let's add, and you get that synergistic effect.
No, completely agree. I think the land of the Cleveland Guardians also prefers statin therapy given the data, and they swept the Angels today, so it's a particularly good day in our land today.
Well done. Well done.
Are we comfortable with lowering LDL cholesterol to the 10s or 20s with the intensity of lipid lowering therapies we have? Are we comfortable with patients who attain that level of LDL cholesterol lowering, assuming that they're high risk, or this is for secondary prevention?
Great question. I have some of my colleagues at Hopkins are true evangelists with lower is better, and I try to diplomatically remind them that when you're getting down to 30, I can't think of a real good study that says 20 is necessarily better than 50. And then I usually bring up the concept of pill burden. So many of these people who get down to the 10 or 20 range are on a PCSK9 inhibitor. And I think especially if they're on ezetimibe, I may very well try to decrease the number of days a week first that they take that ezetimibe, and maybe 3 or 4 months later check another lipid panel, and if it's still way down in that 10 to 25 range, I might just stop the ezetimibe altogether. I think we run the risk of many times just we're prescribing so many medications for the cardiometabolic state, for blood pressure, and when we get to being on 2 or 3 lipid-lowering medications, and we have someone whose LDL is 15 or 20, I think I sort of say, well, we can reward you, so to speak, by all the good things you've done with your lifestyle habits, and maybe if we're going to continue that second medication, maybe we may not give you the statin as frequently if you're already on a PCSK9 inhibitor. So try to use a little bit of psychology, with the patient, and but many patients, as we all know, would appreciate being on fewer pills a day if we can somehow manage that.
I think I love that answer because I think we're not really worried too much about the LDL cholesterol being too low, but the idea of using this attainment to decrease pill burden and improve quality of life, it gives us that ability to do that with these intensive therapies. Do you use LDL particle number or LDL particle sizes for decision making?
So in our guideline, Ashish, we said that we didn't recommend routine use of say the NMR spectroscopy determinations for LDL particle number. In our mind, the ApoB in addition to the LDL is really all that you really need. But I think so you get comparable information between the LDL particle number and the ApoB, and it may be in some institutions that ApoB is much more expensive than getting one of the advanced lipid tests that gives you LDL particle size and particle number. That's not our experience here in the land of the Baltimore Orioles, but we did beat the Yankees today. I think it was 7-0, but hasn't been a great season for the Orioles so far. But I think that there's always a give and take with the patient, and trying to help them. We pretty much know that much lower numbers are better, and we also know that if we can motivate them to improve their lifestyle habits significantly, that's going to pay big dividends. So I think there's a lot of people who are set in ordering LDL particle number, but in terms of the particle size, I think that to quote Charlie Hennekins, who previously was at Brigham and Women's, he always would talk about the totality of the evidence. And in my mind, the totality of the evidence is that lowering both large LDL and small LDL has similar prognostic value, and ApoB is probably the most cost-effective way of looking at the number of particles. But we'll let the different companies, try to prove to you and me if they have a better way of expressing risk than just the plain ApoB.
That's great. Yeah, agree fully with that. Now, here's a question about the use of therapies beyond statins and ezetimibe. If there's an individual who doesn't respond to a monoclonal antibody PCSK9 inhibitor, what's your next step at that sort of advanced stage? Do you add bempedoic acid? Would you consider replacing the monoclonal antibody with the siRNA PCSK9 inhibitor, inclisiran? Would you think about something else?
Yeah, great question. So many times we're starting off with the high intensity statin and ezetimibe, and then we have the choice. Some patients would say, Doc, I'd much rather you give me that combination pill of ezetimibe and bempedoic acid than Nexlizet. And others would say, I like the idea of going on a PCSK9 inhibitor. The commercials are really good on TV, and it seems like a clean mechanism of action. So they'd rather go that way. But so much depends. I think it's so easy for you and me. We've seen a lot of patients, and it's pretty easy to, whether it's the alirocumab or the evolocumab to administer, but for some people, there may be some hesitation. We have found at Hopkins, in our director of the Advanced Lipid Disorders Center, that's part of our Chicka-Running Preventive Cardiology Center, Seth Martin and I've shared some patients where, for reasons that we couldn't explain, patients may have started off on alirocumab, didn't get that great a response, and then switched, to the other PCSK9 inhibitor or vice versa. So you may start off with evolocumab and switch to alirocumab, get better values, and then also we also have had people who we've went with an inclisiran, and they've had what seems to be a much more robust response. So we're hoping that the clinical trials with inclisiran that should be out in the next 2 years will be as promising as the recent studies have been, like the Visalia study and Fourier and Odyssey outcomes.
No, that's great. And with all the different therapies that we have, I think, there's never one right textbook answer to many of these questions. A lot of it, as you pointed out, depends on what the patient wants, what the LDL goals are, what the resources are, what their health coverage is like, insurance is like. And, we have options to switch the PCSK9 inhibitor. We have options to add bempedoic acid. We have options to switch to inclisiran as well. So a few questions coming in, Dr. Blumenthal, on the same topic, which is there concern about the use of statin therapy in individuals with a family history of Alzheimer's dementia or dementia in general? In other words, are we worried about neurocognitive effects in any situation?
So Seth Martin and I worked with one of our residents a number of years ago on a good meta-analysis looking at the studies, and that found that, if anything, the trend was for less cognitive impairment and less dementia. And more recent meta-analyses have also, found that. But there was a former president of the American Heart Association who, was very clear and to me and to others that he felt like he had some, a memory impairment when he was on a statin, and it just, for whatever reason, maybe something genetic in a certain subset of people, it may, they perceive that their memory isn't as sharp. But I think the audience should be reassured that the totality of the evidence would suggest that, if anything, statin therapy leads to less cognitive problems. And the way I usually explain it to them is that, patients developing less atherosclerosis and their carotid arteries and the smaller arteries leading to the head. But, patients, if they perceive that, cognitively they're not as sharp or their memory isn't as good, then it's a reason to, think about another mechanism of action. And thankfully, as you said, we have a lot of different therapeutic choices nowadays.
That's great. No, I completely agree with you there. So we're almost at the hour. Incredible. And we have so many questions coming in. I think this could have been a 2 hour or 3 hour session. But before we turn to our final questions here, to the audience, please take a moment to click the survey link in the chat box to complete a short survey. Your feedback helps make future CardioCore lectures even better. With that, we're over 7 p.m. now. What an engaging discussion. Thank you for the fantastic lecture and for answering all these questions. And to the audience, thank you for joining us today. And we look forward to your feedback, and we look forward to you joining future CardioCore lectures. Thank you, everybody, and have a great day or night, depending on where you're logging in from.
Thanks so much, Ashish. You did a fabulous job.
Thank you.